I hope you are able to see me. We've got a little bit of a low connection issue here with our internet, but I welcome you all. This is I Care for Your Brain with Dr. Sullivan, and that is me. I am a board certified neuropsychologist. I am here in North Carolina, and I wanted to be able to reach more people with the very important model of care that is neuropsychology. I really believe strongly that this specialty area is very powerful in the high level of education and information that it offers to people who are living with a variety of brain health challenges, and also the psychological tools that we mustn't forget that people with brain health issues really require. This cannot simply become a medical issue. Brain health issues, of course, involve the self and the spirit, and we cannot allow medical care to be limited to just talking about MRIs and blood tests and all of the objective things that we can measure in things like laboratory tests, right? We have to be able to speak to the human beings who are living through the brain issue and really serve them and figure out exactly what it is that we can do to help them. So that is my purpose in being with you here tonight. We are also still celebrating the release of our interactive stroke recovery guide. It has been a pretty amazing 2 weeks around here. We're getting calls and emails all the time trying to figure out through these community partners that we have in the world how to get it out there, and we're just very busy trying to find the very best folks to partner with us so we can disseminate it out into the world. Every Wednesday night at 6 o'clock, we like to meet here for a very informative lecture, and I take my inspiration from you all. People get in touch with us, send us messages and say, hey, how about a talk about this, or I'm living with this, what are your thoughts about that? And what we're going to talk about tonight is cavernous angiomas, and I'm really excited because it gave me a great opportunity to learn. The reason this all came about is a really cool guy named Gary reached out to me, and he runs a Facebook group called STEMIs. And STEMIs are folks who have this issue, cavernous angioma, in the brainstem. And I'm actually going to be over there on their Facebook Live tomorrow doing a live interactive lecture on this topic, but even more specific within brainstem. And I thought, if I'm going to try to do that and support these folks, I need to learn as much as I can. But what I wanted to say before we start tonight is this is one of those really awesome experiences for me as a neuropsychologist where I kind of stumble into this very specific specialty world of a specific disorder, and I find people there who are so educated and so well informed about their condition that the truth is they're teaching me. So the truth is I have never, in my 8 years of independent practice as a psychologist, I've never formally evaluated someone who had, that I know of and that they know of, a cavernous angioma. So I had a lot to learn. And so there are some things that I talk to you guys about here, and I feel very strong about my expertise. And I'll tell you, this is what I know about stroke and what I know about Alzheimer's. This is a new thing. There are a lot of threads that I know a lot about, like the recurrent hemorrhages that seem to happen in cavernous angiomas, but I really am open to learning and wanting to know more about y'all's expertise. So you guys can chime in here, write me later, tell me if I got something wrong, tell me if I got it right, all that good stuff. So again, my goal is science-based information, and let's address the psychological side of brain health issues. So this is going to be a lot of fun for me tonight. So welcome to a lot of you out there listening. So the thing about a cavernous angioma, first of all, is it is a issue that goes by many different names. Some people call it just CA. Some people call it a cavernous malformation. It's been called a cavernoma, a cavernous hemangioma, berry brain, and most recently I heard it called popcorn brain, and I ran that by Gary and he told me he had not heard of it. But if you actually look at an MRI image of a brain that has a cavernous angioma, lo and behold, it looks like about 2 or 3 or 5 pieces of popcorn all stuck together. And this is because what a CA is a cluster of abnormal blood vessels, and the walls of these little clusters, they call them maybe like little mulberries, is very, very thin. These are little tiny capillaries that have very leaky walls. There is not a lot of high flow blood that comes through these cluster of abnormal brain cells, which is why it's not quite as catastrophic of a brain bleed as if you had something like a big hemorrhagic stroke or like a vascular malformation, an AVM, something like that. When those things burst, the brain is under a ton of pressure. That's not really the issue with CA. CA is more like slow, leaky over time with occasional big bursts. But even when the bursts are really big, it depends on the location, but typically they're not quite as extreme and require things like shunts and craniotomies as much as other types of vascular issues. One of the big problems though with CA is because it's kind of either always very slowly leaking or it's prone to these bigger bursts of blood, there is a lot of red blood cells and the iron in red blood cells that gets left behind and kind of lives in the berries and around the cavernous angioma. Kind of like chronic low-level bleeding. And the problem is that the iron, they actually call this hemosiderin, this compound is very caustic. Think like oil and vinegar in the brain. The brain does not like this stuff leaking out, and it can become very agitating, very irritating to the brain, and this is when we can have seizures. And so we're going to talk tonight about all the symptoms of CA, but one of the issues is really from this blood just kind of always leaking a little bit. We know that it can occur anywhere in the central nervous system, including the brain, and of course it turns out where in the brain you specifically has a whole lot to do with how much room is there to be able to accept the expansion of blood. There's so-called eloquent areas and non-eloquent areas, and that really determines your ability to have surgery and to get these abnormal brain cells taken out. So we're going to touch on all of that tonight. It's relatively uncommon. We think about 0.5% of people in the world have these. More than 1 million Americans are living with it now. And we think about 20% of those folks have more than one. It is found in all races and all ethnicities, although Hispanic Americans from the southwest region of the United States, one of my favorite areas, and the northern states of Mexico are thought to be more vulnerable because of some genetic mutations that happen around there. People with CM, as I understand it, with CA, may experience acute issues, meaning in a moment there can be a big change. There can be subacute, which means it builds over the course of a few days. And there is chronic, which means it's kind of always there, a little bit of some effect, right? And typically the thing that makes the symptoms go up and down is that hemorrhage, that bigger bleeding that can happen. What is really crazy about my research in CA is that there were, before about 2011, a couple papers kind of written here and there, but there weren't any clinical guidelines that were set forth, even though we have that for all sorts of, every brain tumor you can think of, every type of stroke. There's like these listings, these clinical guidelines for disease management based on all the evidence that comes together, and these groups of professionals basically give clinicians, doctors, these decision trees that say, if this happens, this is what the research suggests is your best bet. Well, this wasn't happening in CA. So actually in 2011, the Cavernoma Alliance UK, which is a patient support group commissioned in England, they asked a scientific advisory board, hey, don't you think it's time you guys came out with some high quality guidelines for us? Well, they looked at the literature and basically they said, we are unable to make any specific recommendations because there's not enough good evidence out there. So that kind of stalled. It was not until 2017 when a project was initiated by the Angioma Alliance in the US, this is kind of the United States version of the UK one, advocating for better patient care and research, came out and got a group of expertise and patients together, and this was a set of guidelines finally published called the Guidelines for the Clinical Management of Cerebral Cavernous Malformations, Consensus Recommendations. So finally we had diagnoses for guidelines for diagnosis, monitoring, and the treatment of the lesions, but also what are the symptoms, the hemorrhages and the seizures, these kind of things. They also got the gaps in the current research understanding out there, the controversies, the things where doctors kind of are walking in gray territory where they're not quite sure what to do. And I incorporated a lot of this paper and these guidelines into my lecture tonight. But what I'm going to do when I'm done is I'm going to post a link to the full length guidelines, because my big thing is I want you all to be very informed. And if I'm sitting here referencing it, why shouldn't I also share with you the primary reference? Their approach was very patient-centered. You know, that's a big thing that we talk about here that we all want, which is care should be personalized, right? It should come, the needs of the population should come from the population. We should be talking to people who live with these issues to find out what their needs are. So they brought a multidisciplinary writing group together that had doctors, invited experts, patients, and they really focused on 5 key areas, which were, you know, what are the prevalence rates? How many people have this? What is the so-called natural history? What happens to someone with a CA over time? They wanted to focus on genetic testing and counseling. Who should get that? What were the diagnostic criteria? When you look at an MRI or a CT scan, what should someone see in order to say we think this is CA? They also wanted to know about neurosurgery and neurological management. How often should people get scanned? How many times should you see your doctor? These kind of things. So for each topic, they developed specific questions that were formulated, and then they presented these also to the Angioma Alliance patient community. And that's where I really applaud these people, because that is key, to have all types of expertise at the table, not just a bunch of doctors who don't have the issue sitting around pontificating about what should be. We need the expertise of people who live with it and the expertise of neurologists, neuropsychologists, neurosurgeons, all these smart people coming together. So one of the things that stands out to me about CA is what I kind of think of as like the journey to the diagnosis. There are a lot of people who live with chronic, unidentified symptoms that really go on a search to figure out what is wrong with me. A lot of these people complain of having headaches. They just kind of feel poor balance. It really depends where in the brain you have the CA or the CAs that determines your symptoms. But many people kind of either find out by accident, because say they have a fall or a car accident and they get a scan and they didn't have symptoms, or it just seems like the MRI was kind of done as a last resort. And sure enough, oh my gosh, you have this thing, and then, you know, it's usually in your 2nd to 5th decade of life where you find this out, and I could only imagine that it's very startling, and, you know, a lot of people have told me it feels like kind of a ticking time bomb is in my head, because I don't quite understand exactly what triggers it, what can I do to prevent it from bleeding. So all that stuff feels very psychologically relevant to me, and it's something that I want to try to help people with a little bit. Part of the reason we haven't gotten super far with CA in the research world is because it's really best visualized on an MRI, right? And the first scan only happened in 1978, and then clinically, in terms of being accessible to people in most hospitals, it's really only been in the late 80s to early 90s that most people have access to an MRI. So what you look for in an MRI is, of course, kind of these small little clusters, like I said, the berries or the popcorn. But really what they're often looking for is a halo around the little berries, which is basically the indication that there's been some kind of bleeding. MRIs and CTs, really all kind of imaging, is very fascinating because, of course, it is in black and white. And so what these amazing people, radiologists, are looking for is very fine changes in contrast, right? So you have pure black and pure white, and then in between is the amazing world of grays. So, you know, super, super light, light, not so light, right? So radiologists basically understand that around the CA, what they're looking for is this halo, and that would be an indication to them that there has been a bleeding. The big study seemed to have come out in the late 1980s. This was published in the Journal of Neurosurgery, and what they did is they actually looked at all the MRIs that were done at the Cleveland Clinic from 1984 to 1989. And the first question they had was, okay, out of these 14,035 MRIs, how many people had CA? And it was 66. And of the 66 that had it, 57 had symptoms from it. So that's another, 9 that had it but actually didn't have any type of symptoms. They followed these people over time, and most of them showed evidence of low-level chronic bleeding, and there was signs of hemorrhage in 7 out of the people that they followed over time, and only 1 out of the 66 people had a pretty big hemorrhage that required some type of surgical intervention. The annual bleeding rate for this group of people was less than 1%. There was a significantly higher risk for a bigger hemorrhage in women, which brings up the possible role of estrogen. I did a talk a few weeks ago about stroke symptoms that are unique to women, and that taught me a lot about how much we don't know about estrogen in the brain and how that mediates brain recovery and brain injury. It's pretty important stuff that we don't really know a lot about. CT scans are important to talk about because your doctors and the hospitals could potentially push you more towards a CT scan. A CT scan is what we call quick and dirty and cheap. It's quick, it's dirty, and it's cheap, right? So dirty means the image is not very clear, it's not very crisp. I kind of think of it like an older black and white photograph. Whereas, and it takes a couple minutes, you're in, you're out, and it costs a lot less. MRIs, it's more like a very clear black and white photo taken with a really, really good camera. And the better, the more powerful the magnet, the more picture perfect the image is, right? So CT sometimes is needed. If you're having acute symptoms and you go to the emergency room and they need to figure out if you're having a major bleed that's going to require a craniotomy, that is okay to get a CT. But for the most part, I really want you all to be advocating for yourselves to get MRIs. More and more, the way the medical system is changing, we're going for, to just call a spade a spade. It's trying to cut costs at every turn, so cheaper, cheaper, cheaper always seems to be done more and more and more. But there's certain times that you just really need to push it and talk about the clearer ability of an MRI to look in the brain and actually see what's going on. So like I said, for some people with CA, CTs can be good in an emergency type setting. But what we worry about is how often people with CAs seem to need imaging. And we're going to talk about what those recommendations are. But every time you get a CT, you're actually getting a little bit of radiation. And so there's no solid proof that this is damaging to the CA brain. But, common sense just tells us why go through that. And if the only reason we're doing it is to save money for a hospital system, forget it. We need to be doing some advocacy. It's just a small dose of radiation for every CT scan, but, we don't want someone having 20, 30, 40 of them in their lifetime. So let's talk about symptoms. 20 to 50% of people with cavernous angiomas don't have any symptoms. If you do have symptoms, it's typically because of the location of the lesion or the mass or how many you have. The most common symptoms are seizures. We think about 50% of people with symptomatic CAs have had at least one seizure. Having one seizure doesn't necessarily mean you have epilepsy. You can have one seizure and never have one ever again. We think seizures are more common in children who become symptomatic. The next symptom is headaches. And a lot of times there can be what we call a pressure effect or a mass effect, which is basically depending on how big the bundle of abnormal blood vessels are or their location, how much room they have to kind of expand with blood after the bleeding. It's more that you get symptoms because of how it's butting up against the brain, and the brain has a remarkable ability to twist and move and to go into little side areas. That's why sometimes if you have a big enough bleed or a space-occupying lesion like a tumor, you can actually see something called a midline shift, where the left and the right brain can actually cross the midline here and go over and squeeze all the way up into one side of the brain. It's pretty amazing. We get very concerned about brainstem CAs, of course, because we get worried that in that tight little spot back there, we can get what we call a herniation, which is basically there can be so much blood that it basically compresses the brainstem. And the brainstem does a lot of very important basic vital functions, so we get very worried about that. Mass effect is what can cause the things like weakness, numbness, double vision, visual disturbance, and the language issues. It's typically not the actual lesion and where it is. It's more like if it gets big enough or it bleeds enough, it starts to push on brain tissue, and whatever function is subserved by that brain tissue is where we get the symptoms, okay? So just a little bit more on seizures. So remember, like I said, we always kind of have this leakage of a small amount of blood with CA, and not only is that caustic and kind of causes that oil and vinegar issue, it also does damage to a part of the brain called glia. Now these are non-brain cells that are in the brain and kind of like the insulator or the connectors between different parts of the brain. So kind of is like the support system for the brain. And if those get inflamed and ultimately have some damage to them, then the brain just isn't as interconnected. It's not as able to communicate as it was before. And a lot of times when that happens, we can have irritability in some sections of the brain, and it can kind of cascade into a seizure. But we get most concerned about hemorrhage, like I said, in folks with CA, because there's only so much space up here at this brain hotel. And if there's other visitors that don't really have a room, then they have to go somewhere. And like I said, that's when the brain can start to shift and move, and that causes brain cells to stretch and not be connected to other parts of the brain. Or if it goes, too far back, that's where we can get into issues with the brainstem, which is the main connector between the body and the brain, and where a lot of vital functions like breathing and heart rate and all that stuff comes in. But you guys might be surprised to know that it was only until 2008 when the definition of a CA hemorrhage was actually agreed upon, and this is what it is. It requires acute or subacute onset of symptoms. So any of these, a headache, a seizure, impaired consciousness, and it must be accompanied by radiological evidence of a recent bleed. This is the main reason for moving ahead with treatment. If there is a connection in time, a timeline that matches up between symptoms and evidence on some type of imaging to make the conclusion that those two things are actually related. The annual risk of hemorrhage in the literature is anywhere from 0.7, so less than 1%, all the way up to 6.5%. There is a risk of first hemorrhage of about 0.4 to 2.4. But it seemed to me in my review of the literature that once you have a hemorrhage, you kind of switch over into this other category, and you're much more likely to then have recurrent hemorrhages, which makes sense because brain damage oftentimes can kind of beget more brain damage, especially if it's not a one-time thing. So remember I said before, this is kind of like slow, leaky capillaries that are letting a little bit of blood out. The brain doesn't want blood in it, and so there's kind of this constant kind of low-level injury that's happening. So all studies have reported higher rates of recurrent hemorrhage than first-time hemorrhage, okay? But the meta-analysis that I read also said that over time, you do tend to get less and less hemorrhages. So it seems like once you flip over from having one, you're in the category of having more than one, but over time, there actually is a decline in the number of hemorrhages that you're gonna have. So I thought that was helpful. So what I would want to know if I was someone with CA is what exactly is happening during a bleed. Well, like I keep saying, blood irritates brain tissue, okay? And when brain tissue gets irritated, it swells, mostly because the immune system is trying to send in all these specialized cells to munch away all this stuff. And this is called edema, right? This is just basic swelling. So what can happen with CA is now we've got this pooled blood that is outside all the little berries, and this is basically turns into kind of a mass, and we can call that a hematoma. All of this extra stuff creates pressure in the brain, which then also reduces overall blood flow because things are too tight and blood can't move freely within the blood vessels of the brain, right? And over time, not having optimal blood flow kills brain cells. And so the symptoms of brain hemorrhage can vary quite a bit. Like I said, depends on the location, how much bleeding, how much tissue is affected. Symptoms from a hemorrhage can appear very, very quick. They can go slowly over time. They can get a little better. If the bleeding retreats, it can get all of a sudden really worse. It's really hard to know. The biggest risk factor for bleeding and CA goes back to the brainstem, and these are the STEMIs that I'm going to be talking to tomorrow. So this has been shown in many individual studies and conclusively by a meta-analysis. People with brainstem CAs have a higher rate of hemorrhage, and it can go from, and now this is wild because the research is all over the place, but 2 to 60%, so 2 to 60%. Some of the risk factors, again, are being a woman, how big the CA is, and if you have more than one. So again, like I said before, within the brainstem, which is made up of 3 specific structures, the midbrain, the pons, and the medulla oblongata, which is one of the funnest names in all of the brain, this controls basic body functions, breathing, swallowing, blood pressure, consciousness, awakeness, sleepiness. And it's a tight little fit back there. We don't have a lot of room for extra blood. And so when there is compression, this is when we get very worried about a catastrophic outcome, which is basically somebody could die. So one of the things people kept asking me was, I don't know when I should get scanned. And so I researched this, and it seems like there's two considerations. So one is after an event, if you feel like something has happened, that there's been a hemorrhage. And another one is part of routine care. So what they say after an event is that it should be done as soon as possible, MRI of the brain, in order to correlate it with the clinical symptoms. What has been found is that within a week of the onset of the clinical event, you should be able to see evidence of a hemorrhage. After about a week or two, there's certainly still blood in there, but it might not be strong enough, big enough of an area to actually visualize on MRI. What's much more controversial is how many times you should get scanned if you're asymptomatic or you don't feel like you have a clinical event. There's actually no well-established guideline for this. It is dependent on insurance, which of course drives us all nuts, your preference as a patient, your neurologist's preference, your neurosurgeon's standard of practice. I know they are trying to meet. There's been 2 annual international conferences in Switzerland where they're trying to figure this out, but as far as I understand, they have not. It's really dependent on the symptoms that the person has. There are 3 causes of CA as far as I know. That's sporadic, which is where we don't think it has any genetic cause. There's the familial form, which means there's a genetic mutation, and after radiation therapy. Most people have sporadic with no family history, and many people have typically 1 CA. We think about 20% have multiple. There are 3 genetic mutations that can happen, CCM1, CCM2, and CCM3. The recommendations that they make for genetic testing is basically to look back on your family history, and you may not know if people had CA, but do you know that they complained of frequent headaches? Did they have seizures, right? Did they ever have to go into the hospital and you didn't know why? The goal is to basically be able to then recommend genetic testing to adults so that they can engage in informed family planning. It gets a lot more controversial if you are someone who actually doesn't have symptoms or you don't have any family issues, because that's a whole interesting world called neuroethics, which is, you know, you really need counseling for that. What would you do if it is genetic and you just recently had triplets? You know, it can create a lot of undue anxiety for something that may or may not stay asymptomatic, right? Would you, very much a personal preference, would you prefer to know that you had this, or would you prefer to kind of not know, right? So only you could really decide that. In terms of long-term functioning, again, we're really in the dark research-wise. There is no standardized tool for assessing how people with CA do over time. And that really ties the hands of scientists, because if you can't compare one patient group in Zurich to a patient group in Jacksonville, Florida, we're kind of talking apples and oranges. So it's just really, really important that we start to develop these research tools, because that's how ultimately clinical good decision-making happens. We do know, though, that people get treated for the symptoms. So with seizures, obviously you go down the seizure protocol. The big question in my research seems to be to have surgery or to not have surgery. So surgical removal of the lesions they consider to be the best possible outcome, but of course it depends on your age, if you've had other hemorrhages, where is it? We get very concerned about so-called eloquent areas. So this is something you might find in the research. There's eloquent areas of the brain and there are non-eloquent areas of the brain. So what does that mean? Eloquent areas of the brain are basically areas that are so sensitive and contain such unbelievably important nerve fiber tracts and critical neuronal pathways that are packed into these small areas, and the risk would be of damaging the tiny little blood vessels that support that part of the brain. And if you take those away, all those little roots, all those fingers, when you take away the CA, that maybe that is also feeding other parts of the brain that don't have any backup blood flow, and you can get unintended effects like losing vision. You know, and again, it's location, location, location. It really depends exactly where it is in your brain. So within surgery, there's resection, which is kind of like standard. But what I kept reading about is radiosurgery, and this is a little bit more like, you know, the robotic, computer-guided intervention that can happen, and they're thinking that this is kind of optimal because it's much more precise. You get less overall injury to the brain, because let's not forget, a craniotomy is its own form of traumatic brain injury. You often have to cut through healthy brain tissue to get to the problem, no matter what the issue is. And in research anyway, we think that these folks have a better clinical outcome, especially in these so-called eloquent areas. The problem is, though, is that the research is being done in these super specialized clinic centers, and it's not necessarily been tried in the community. So it's not really accessible to people now, and we don't really know how well can institutions afford the training to send their people, right? There's a lot of like practical medical rollout that would have to happen in order to make this a service that was available to more people. One of my questions was, well, what about rehab when you have CA? So the idea is that basically symptoms should mostly resolve on their own. I did not see any guidelines or guidance about what types of physical rehab, cognitive rehab, any of that stuff. I couldn't find any literature on that at all. The goal is to reduce the chances of having a hemorrhage, a bleeding in the brain, and to try to return to independence, weight bearing, and emotional health as soon as possible. But yet there were really no tools out there that I could find. So what we do in a lot of issues like this with the brain is you look to other literature to see, okay, well, who is preventing intracranial pressure, which might be one of the risk factors for developing a hemorrhage. So I kind of went down that road. And there are some guidelines for what not to do that are out there that maybe some of you with CA know. So they say trying not to do anything above 10,000 feet, because that can create hypoxia in the brain, which is just a lower level of oxygen saturation in the blood. And you shouldn't smoke, right? We all know that one. Contact sports, not wearing a seatbelt, anything that you could do that might suddenly jar your brain. Strenuous exercise, heavy weightlifting, swimming alone, all these kind of things. I was in touch with the organizer of that Switzerland conference because they really focus on brainstem folks. And actually tomorrow when I'm over at STEMI's at 4 Eastern Standard Time, I'm going to tell you about my emailing with this really awesome surgeon. And basically the short of it, what he told me is he didn't find that physically strenuous activities seemed to be a risk factor, but that he and his researchers had a theory that psychological stress and pressure might actually be a bigger risk factor. And he was very curious to know what I thought of that, and asking you all who've had multiple hemorrhages if you found that they seemed to happen during a time in your life when you were going through a lot of stress. And I think that that's a very important bit of information for me to gather from all of you so I can bring it back to him over there in Switzerland. So I appreciated learning about CA, but I have to tell you, if I feel frustrated by the lack of information out there, I can only imagine how you all who are living with this feel. I go through, all of these scholarly literature searches, and I'm trying my best to sift through all this information, but there's really just not a ton out there. I did learn more about brainstem specific CA that I'm going to be sharing tomorrow with STEMI's, and then actually next Wednesday when I'm with you all, I'm going to be doing a formal talk just on that specifically. But really, it seems to me like a lot of people are having to reinvent the wheel, are having to share information between them. And that's why I really take my hat off to Gary, because I just think that's so helpful and so cool to bring together people in a Facebook group from all over the world for free, where people can share experiences, and this worked for me, and here's what I found, because I think that's really how people can best take care of themselves now. Of course, you have to partner with your neurologist and your neurosurgeon and your neuropsychologist, but really, I think learning from each other is probably one of your strongest suits at this point. So what I'm going to try to focus on next time is a little bit more of the psychological coping. How do you cope when you feel like you don't have a predictable brain where you know what exactly is going to happen? How does it feel to live with a lot of uncertainty and anxiety? I'm going to try to think through strategies that might help you all out there. If you all are listening and you care about someone with CA, I hope that you feel like you learned something. If you have CA and you're listening to this, I hope I at least added just a little bit of new knowledge, but I think the truth is really you all have a lot to teach me. Thank you guys so much for being here. I will see you next week. And don't forget, Interactive Stroke Recovery Guide available on our website, www.icfyb.com. Thank you all for being here. See you next time. Bye-bye.